Moving forward to the next session about management of complex renal cysts. To moderate the session, I cordially invite Dr. Hilary Fernando and Dr. M. Taha onto the stage. Over to you, sir, to introduce the speaker.
Thank you very much. Over the next 15 minutes, we'll hear about management of complex renal cysts. It is my great pleasure to invite Dr. Ranga Wickramarachchi, consultant urological surgeon and senior lecturer from the Faculty of Medicine, General Sir John Kothalawala Defence University. Over to you, Dr. Ranga.
Okay. Thank you, Hilary, for the introduction. Good afternoon, ladies and gentlemen. And thank you for the opportunity, and it's my great pleasure to take you through management of complex renal cyst over next 15 minutes or so. I have no disclosures. This is the outline of my presentation. As we all aware, cystic disease of the kidneys, it's pretty common. The detection of complex renal cyst has increased with time over past 2 decades, I would say, due to frequent use of cross-sectional imaging. And out of all the cystic lesions, we know the cystic renal cell carcinoma represents 5 to 7% of the tumors. And the difficult part is differentiation between the benign and malignant lesions. It remains a major challenge for the radiologists and for the urologists to deal with it. So what is a complex renal cyst? Before coming to a complex cyst, we will start with a simple thing. The renal cysts are divided into two, complex and simple. A simple cyst is defined based on the ultrasound scan findings of a round oval shaped lesion, homogeneous consistency, contents, and no internal echoes, posterior enhancement, and the wall should be sharp, thin, and very smooth, and could not be separated from rest of the renal parenchyma during the ultrasound scan. So for you to call it a simple cyst, the cyst has to fulfill all the criteria. If at least one or more criteria is not fulfilled, then those cysts will be classified as complex or atypical cyst. Now looking at Bosniak classification since its inception in 1986, which has initially divided renal cyst into 4 categories, Bosniak 1, 2, 3 and 4, based on contrast-enhanced CT, and later on it had 2 modifications, one in 1996 where a new category, Bosniak 2F, has been introduced, F for follow-up. And later on in 2019, the MRI has been incorporated into Bosniak classification. So the present day, what we use is version 2019 classification for our clinical practice. Since its inception, it has been the main the modality that we classify renal stones to decide the further management as clinicians. So if you look at the Bosniak classification, different grades and the risk of malignancy, you could clearly see Bosniak 1 and 2, the incidence of malignancy is less. However, when you move upwards from 2F, 3 and 4, there you have a marked rise in the incidence of malignancy, and some of these series they have shown the malignancy rates are more than 80% in Bosniak 4 cyst. Here I am quoting some of the articles, these are systemic reviews which appeared in 2022. Here you could see the paper based on pathological assessment of renal cyst. Therefore, they have noted the 2F incidence is quite high as 28%. That is, I think it's the selection bias because the people who were under surveillance were not included in this study. Therefore, obviously the post-operative, the specimen has, or the biopsy specimen have shown higher percentage of malignancy in renal cyst here. So when it comes to the management, starting from the diagnosis, treatment and the follow-up, the entire spectrum is a great challenge. The main reason is we don't have enough evidence or the robust data to clear to give us a clear guidance. Whatever the available data, basically the guidelines based on the expert opinions, case series, and so on. So if you diagnosed a complex renal cyst in your ultrasound scan, obviously the next step you need to move ahead with a cross-sectional study, and that will help you to characterize the cyst in detail, and thereafter you need to apply your version 2019 Bosniak classification to decide as what to do. So the contrast enhanced CT has remained the gold standard despite all the other imaging modalities, but one has to realize there is a significant inter-observer variability. For you to get the best out of the CT, you need to conduct the CT in the accepted triphasic kidney investigation protocol, where you look at the pre-contrast and post-contrast images, and particularly the nephrographic phase is very important. So I have here indicated the features of a complex cyst or an atypical cyst in a CT scan. The image next to it shows a cyst with multiple septae, and of course it's a small image. If you have a close look, you could see enhancing wall in the inferior part of the cyst. So when you get a complex renal cyst, despite having all the modern imaging modalities, still we do have a challenge. The main challenges are to differentiate non-malignant lesions from malignant lesions, particularly the inflammatory lesions. It's quite a difficult task at times. And then we have the cyst with complications such as hemorrhage and differentiating from complex cyst. And sometimes the solid tumors with central necrosis can also interfere with our interpretation. And obviously the Bosniak 2, 2F and 3, there's a subtle difference, and sometimes even the best radiologist will find it difficult to point out exactly what it is. Therefore, the contrast-enhanced MRI and the contrast-enhanced ultrasonography has been increasingly used to get further details about this cyst. So what is the role of MRI in diagnosis of cyst in the current day practice? Except for calcifications, all the other morphological features, the criteria identified in the contrast CT will be shown with the MRI, provided you do the MRI with the analysis of T1 and T2 weighted sequences. In addition to that, gadolinium contrast enhanced fat saturated dynamic sequences will tell you more about the wall vascularity, particularly in a solid component. The MRI is quite useful, demonstrating poorly identified septa in a CT, and also you can see the subtle enhancement which is not clearly visible in the CT, and which will differentiate hemorrhagic cyst from other solid enhancing masses. When it comes to the contrast enhanced ultrasonography, there is promising results, and the advantages are less expensive, time consumption is less, and the potential nephrotoxicity, particularly the renal function impaired, it's very valuable. It has a good diagnostic sensitivity and accuracy. However, the specificity is lower than the MRI. Unfortunately, this is a newer modality, and still we have only limited data and paucity of comparative studies. Therefore, we can't apply contrast enhanced ultrasound scan across the board in standard guidelines. In addition to that, the studies have shown that the MRI and contrast enhanced ultrasonography, there is a tendency to downgrade or upgrade some of the lesions. Considering all these things, the recommendation up to now that the role of MRI and the CT, MRI and the ultrasound scan, contrast enhanced ultrasound scan, mainly reserved for the lesions that are difficult to classify or indeterminate with your CT alone. They are for the way forward multimodal diagnostic approach. So how about the role of percutaneous biopsy? Of course, the available evidence is more conflicting. The way back in 2002, here you could see the one study has shown a very good identification rate of malignancy up to 60 to 70%. But we know later in 2014, there is a study shown image-guided biopsy or aspiration cytology is inconclusive in majority of the cases. Even in the solid masses, we know if we get a negative biopsy, how to proceed. Are we going to take the biopsy and decide our management? Will it really affect our management? So the same controversy will apply here. So therefore, the biopsy accuracy remains a concern. So here I am quoting a Canadian guideline where they have recommended biopsy for Bosniak 4 cyst, and if it is, it should be used if there is a significant solid component and amendable to biopsy, or if the result will alter your management. Otherwise, the answer is the biopsy will not help you that much. So when you look at the treatment options available, the spectrum between the surveillance, surgical excision, and the other minimally invasive modalities, the main two factors apart from the patient factors, the tumor or lesion factors, basically based on the size and also the Bosniak classification. Traditionally, any RCC, we urologists used to have a very aggressive approach. However, the newer studies have shown the downside of the aggressive approach. Sometimes the resection of many benign cystic lesions and maybe indolent cancers, it has shown that the Bosniak 3 cyst, if you resect and send for analysis, about 40 to 50% are benign. And there's treatment-related morbidity and decreased renal functions on follow-up, and of course the burden on the healthcare system has to be considered. In addition to that, it is very interesting compared to solid counterparts, these cystic lesions, complex renal cysts, they behave in a better prognostic way. So how about the risk of surveillance? Here some of the studies have shown a risk of observing a Bosniak 3 cyst and also sometimes even the Bosniak 4 cyst during initial period up to 5 years is quite safe. Looking into one study which appeared in Radiology in 2019, where it looked into Bosniak classification for complex renal cyst re-evaluated, a systemic review, which has evaluated 3,036 renal cysts, out of which 373 were malignant, and only one patient developed metastatic disease during the follow-up period. Another study looking into the natural history of complex renal cyst, the numbers are 336 patients, where the Bosniak 2F, 3 and 4, and out of which the majority were Bosniak 2F cyst, and good follow-up period over 5 years, and they have concluded active surveillance of complex renal cyst is quite safe and feasible. If you look at the standard guidelines, the European and the Asian or the American, you can't find much of evidence to justify your practice. The only guideline which we will deal with in detail about the complex renal cyst is the Canadian guideline, which I quote here with the 2023 update, which has looked into 77 relevant studies where they have done a literature search in Medline and PubMed. And this is the conclusion. If you have a Bosniak 2F cyst, the recommendation is surveillance, where the imaging every 6 to 12 months within the first year, and then annually subsequently up to 5 years if there is no progression. If you look at Bosniak 3 and 4, you could clearly see here, in addition to Bosniak class, you could see the tumor size matters. If it is less than 2 centimeter, Bosniak 3, the active surveillance is preferred. 2 to 4, you have both the options available. You have to tailor your management to the patient. And definitely Bosniak, if it is more than 4 centimeter, the surgical excision is preferred. Same would apply to Bosniak 4. And I think this is in keeping with the small renal masses where we know the metastatic risk is less as long as they are less than 4 centimeter. The same theory is applied here. Obviously, when it comes to the surgical treatment, nephron sparing surgery is preferred to the radical surgery whenever it's technically feasible and suitable. And minimally invasive approaches such as robotic and the laparoscopic obviously will have their own advantages over open surgery. And we should not forget the ablative ablation techniques, particularly the thermal ablation, quite useful in some of these patients, carefully selected. The follow-up of these patients mostly depend on the Bosniak category and tailored to the individual patient. Unfortunately, there is no consensus on the ideal protocol, imaging modality to be used, frequency of imaging, and duration of follow-up. Ladies and gentlemen, in conclusion, we talk about the management of complex renal cyst. The differentiation between the benign and the malignant cystic lesions is a major challenge. And the Bosniak classification has withstood the test of time, and it is still in our clinical day-to-day practice. Contrast enhanced CT remains the gold standard for diagnosis. Non-contrast enhanced and contrast enhanced ultrasound, MRI, biopsy, they are used as an adjunct to contrast enhanced CT. And the treatment landscape has shifted from interventions to surveillance. And the evidence for optimal management is of low quality and still emerging. Thank you for your patience.
Thank you very much, Dr. Ranga, for sticking to the time and giving that very informative lecture.